So in this video, we're going to run through the rapid trauma assessment for you and kind of give you an idea what that looks like. Remember, rapid trauma assessment, organized approach, head to toe, to try to find any immediate life threats in our unresponsive trauma patient. So the point of the call that we're at right now is we've already taken care of the scene assessments. We know our scene is safe. We've addressed those issues. We know the number of patients we've got, and we've got additional help coming to give us a hand with this really sick person. So we're going to move right into running through the ABCs for you real quick, kind of show you a real down and dirty ABC assessment. With trauma patients or any unresponsive patient in particular, it's important to remember that we tend to flip the order a little bit and go CAB. So we want to assess for circulation, and then we'll move on to airway and breathing. That's only in an unresponsive patient. There's a couple reasons that we do that. Number one, it helps us to figure out if our patient's in cardiac arrest immediately and start CPR. Remember, good chest compressions is critical to the survival of a cardiac arrest patient. The other reason that we flip that order is we want to get the circulation up front, is because we want to find and address any immediate life-threatening bleeds. Through the study and science that's happened over the last several years in the Iraq and Afghanistan wars, we know that one of the top killers of trauma patients is life-threatening bleeding. So again, detect that early on in your assessment and get it addressed, either through tourniquets or bandaging. And then we can move on and worry about airway and breathing issues. So this is my trauma patient. The mechanism was bad. We don't really need to get into the details of what it was. But as we approach, again, we're scanning the body, looking for any life-threatening bleeds, large pools of blood. Is there spurting or large volumes of blood coming out of a particular area of the patient? If there were, we would jump on those and address those before we did anything else. To begin, we're going to come up and we're going to kind of get an idea, is this patient responsive or not? We're going to use the four-step process of AVPU. So are they alert? Do they respond to voice? Do they respond to pain? If they respond to none of those, then they're unresponsive. Don't forget about the pain step, or to note that they're responsive to painful stimuli. That is not unconscious. So there's a difference there. So as I approach my patient, I go, hey, are you okay? Can you hear me? No response. They're not responding to my voice. So we can try some painful stimuli with the sternal rub. No response from that. So now I can declare my patient unresponsive. First step is I'm going to take and hold on to C-spine. As I'm doing this, I can reach up with my hands, grab a carotid pulse, and know that that's present. And at the same time, I'm looking and listening to the airway, looking for anything in the airway or any type of noisy breathing that would indicate an airway obstruction. And I'm watching the chest for equal rise and fall and kind of get a sense for their work of breathing. So with my patient here, there's no airway issues. They do have a pulse, and their breathing is within normal limits. So I feel comfortable with all of those. My initial assessment is done. At this point, I'm going to move on to the rapid head-to-toe assessment. In order to accomplish that, I'm going to have to let go of the patient's head. So I'm going to hand my C-spine precautions off to my partner. So now that John's got the C-spine locked down, he's got that taken care of. Additionally, his other assignment would be to just keep an eye on the airway, make sure that it's maintained. If there's any issues there that show up, he can get help or address those himself. And if there were any breathing issues where we needed to assist ventilations, all those things, John could take care of those too. A real easy way, if you're assigned to John's position to handle these things, is it's actually legitimate, if we were positioned on the ground, to hold that C-spine with your knees. So that would free up your hands then to providing suction or any assisted ventilations while the rapid trauma survey is happening. So to jump right into the rapid trauma survey, again, remember it's head to toe, so obviously we're going to start at the head. What you're doing is you're wanting to sweep the head and look for any type of obvious bleeding, feel the face bones, and make sure they're intact. As we're working our way down and doing this assessment, we're going to utilize the acronym DCAP-BTLS. And that kind of clues you in as to what you're looking for as you're moving along. So DCAP-BTLS would be deformities, contusions, abrasions, penetrations, BTLS, burns, tenderness, lacerations, or swelling. You may also see the acronym TIC used, which is tenderness, instability, and crepitus. That's typically used for, let's say, like areas where there's bone, so the chest wall, the arms, the legs. You could use TIC in addition to DCAP-BTLS. So we've assessed the head. No instability, no bleeding, did a blood sweep across the back of the head, no issues there. Now we move down to the neck. When we get to the neck, you're looking for the trachea to be center, and midline. If it's abnormal, it'll kind of bow and push off to one side or the other. That's a trachea that's not midline. The other thing we're going to check is the jugular veins, run right down the kind of the outside edges of the neck. We want to look and see if those are swollen and engorged, or what they would call jugular vein distension. So jugular veins are good on my patient. Trachea is midline. I can move around, feel the back side of the neck, palpate that C-spine area, looking for, again, any tenderness, instability, or crepitus. No issues there. So now we've cleared the neck. There's no issues. At this point, we can go ahead and apply a C-collar. So I'm going to take C-spine back. John's going to grab a C-collar. We're going to apply it to our patient. Okay, and then John still goes and holds on. Just because we have the C-collar applied doesn't mean we've completely addressed C-spinal mobilization. The C-collar is really good at preventing flexion and extension, but it doesn't prevent rotation, so someone still needs to hold on. And again, still, John can sit up here and maintain the airway, maintain the breathing. The large window in the C-collar is there so that you can go back and keep an eye on the jugular veins and the trachea to make sure that they're remaining within normal limits as well. So head and neck is done. We're going to move on down to the body. We begin at the clavicles and the shoulders. Again, we're feeling for any stability, instability, tenderness, or crepitus. And since we've got a shirt here, we need to remove the clothing. So typically trauma shears up and towards the shoulders. My guy was nice enough to wear a Velcro shirt for me today, so we get that out of the way. Same deal, just looking for the tenderness, instability, and crepitus. Make sure the chest wall doesn't move. You can pause and feel the expansion of the chest wall with some light pressure. Make sure that it's equal, and you're looking for any areas that are moving differently than the chest wall should. So when the chest wall expands, it goes in. It would indicate a lot of rib fractures. So my chest wall is good. Moving down to the abdomen, we're going to palpate the 4 quadrants. Looking to see if you elicit any type of painful response from your patient, even though we've decided that they're unresponsive, and you're looking for any type of rigidity in the abdomen that would indicate significant bleeding. Abdomen's good on this guy, so we're going to move down to the hips. What we're looking for here is any type of instability. It's best to kind of press in and down. And if you feel that pelvis moving underneath you, you know you've got an unstable pelvis. And then down the legs. When we're sweeping, you want to apply kind of counter pressure on each side of the bone. Don't line your hands up. Offset your hands so that, again, you can feel any of that instability that might be in that long bone. Also in the large long bones, when they get fractured, you'll feel the muscle ball up and knot up. Moving down to the legs. Up the other leg. Kind of glazed over the feet, but obviously we would check them. Again, you're just looking for anything that's like an immediate life threat. Next, back up to the arms. Same deal, right? Opposite pressure, feeling down the long bones, feeling for any tenderness, instability, crepitus, or fall back to BTLS. Back to the hands, no issues there. This hand here. Okay, so at this point, we need to roll the patient. We'd obviously want some more hands here. This guy's pretty light, so I think I can handle him on my own. But we're wanting to check the back, check down the back. Remember that when we get all this done and we roll them up, we're probably going to roll them back onto a backboard. That patient's going to be secured to that backboard, and they're going to lay on that backboard for several hours. So in reality, you're probably the first and last person to get a good look at the back side of your patient for quite a while. So make sure you do a good thorough assessment, and don't forget this. It's an easy step to forget, especially in testing scenarios. So on John's call, we're going to roll the patient up.
All right, on 3, 1, 2, 3.
We can get rid of the rest of the shirt. And we're going to, again, same concepts, decap BTLS or tick, whichever you prefer. You can palpate the entire spine, feeling for any type of step off or crepitus, and then sweep down the backs of the legs. On this patient, we didn't remove their pants. And that's, sorry, that should be on your count. And that's a call that you need to make in the field, right? Are we in a private place where it's okay to go ahead and take their pants off? Can we get an accurate, quick, rapid assessment of any life-threatening conditions with their pants on? Chest wall is always best to expose because that's where all your vital organs are. If there's any significant issues, we want to get eyes on them. As far as the legs, you're really looking for significant bleeding or any bone fractures. So we can typically pull that off through a thin layer of pants. Once we get them secured into the ambulance in a little safer, more private environment, then again, the pants will go and probably the underwear as well, so we can get eyes on all parts of them. So from this point, we would have rolled the patient onto a backboard, secured them, and we'd be ready for transport to get off the scene.